So I do want to get to our speaker, Darrick Duran. He is a Lieutenant Colonel in the He is a Command Public Health Officer, Pacific Air Force's Joint Base Pearl Harbor-Hickam, Hawaii. In his capacity, Lieutenant Colonel Duran is a primary consultant to the Pacific Air Force's Command Surgeon on public health, health promotion, and pandemic and emerging infectious disease issues. He develops deployment health, preventative medicine, and food safety and food security policies for 9 overseas installations and 32,000 personnel. We were talking a little bit before the meeting of a few of the previous pandemics, but I think that this shows that you never know, even if you're prepared. So I'll let Darrick talk about COVID, his thoughts, his role, and how he thinks moving forward. So thank you, Darrick, for joining us, and feel free to start when you're ready.
Okay, good morning, everyone. Thanks again, Evan, for having me on and the team here. Can everybody hear me okay? Audio good? Okay, great. So as Evan was saying, I am a public health officer. There's about 150 of us in the Air Force active duty service, just to put things in perspective. And I've been at Joint Base Pearl Harbor-Hickam for a little over a year now, so I'm pretty new to Hawaii. I'll give you a brief introduction, kind of where I've been and how I've came about to being in this position right now. So originally from Central California, Fresno area. I wrestled at Fresno State University as an undergrad, and I got my Master of Public Health at Fresno State, worked at some county health departments before I came in the military, and also worked at some at the world's largest women's prison doing hepatitis and HIV detection and control as a community-based organization working inside incarcerated populations. So that's a little bit before I came into the military, and since then I've been active duty now 15 years. Before this assignment, I spent 6 years in Germany, working both in U.S. Air Force's Africa and Air Force's Europe, doing a lot of the same types of things that community-based organizations and nonprofit organizations do, working humanitarian issues in Africa, public health issues mainly. As you can imagine, Africa is always a great opportunity to understand public health at its basic core. Also worked on the Ebola response back in 2014 and the military's efforts to support the Ebola outbreak, or yes, the Ebola outbreak in West Africa. Also worked some Eastern European countries, working host nation support to develop their military public health folks. And so a lot of experience coming in, still a lot to learn. And so right now, as Evan said, I am at the headquarters for Pacific Air Forces, and we oversee our installations two out of Alaska. We have one base here, obviously Hickam, here on the island. We also have Anderson Air Force Base in Guam, so we partner with our territory within Guam. And then we have 5 bases in Japan and South Korea combined. So a lot going on. I will start my experience with this particular pandemic actually started on January 3rd of this year. I received an email from our intelligence colleagues within the building I work, and they said, "Hey, Lieutenant Colonel Duran, did you see this report about this mysterious pneumonia going on in the Hubei province in Wuhan?" And I said, "Oh yeah," you know. He goes, "Hey, can you guys give us a little brief on this in about 2 weeks?" I'm like, "Okay, sure." And I would have never imagined that 6 months later, a little over 6 months later, we would be here as far as how this thing has kind of unfolded. And so what I'm going to talk about today, I know the topic is how are we going to move forward. I'm really going to talk about COVID-19 in terms of kind of at the state level where we're at, and then also a little bit about what we can do for our individual communities and our families going forward. And I also touch bases, and I shared a link already with the state health department that will really, I encourage folks to take a look at and stay informed with, and I'll talk about some different data points we want to look at going forward as we as we go forward. So just one quick disclaimer. Obviously, I am active duty military, and so everything I'm going to talk about today, they are, as a disclaimer, they're my opinions only. They don't necessarily represent the views of the DoD, but obviously my experience and my efforts here are based on my experience working in the military side. So the link that I shared, I don't know if everyone can see it, but it is a link to the state health department website, and it uses the Johns Hopkins map. If you guys have seen what Johns Hopkins has done, they work with multiple websites, multiple data sources, all validated. And so Hawaii is able to kind of manage its, the Johns Hopkins map specific to the 5-island chain here. And I really wish I could share this with you, but I will go ahead and just kind of explain in general what's going on. So as you know, we've seen a resurgence, if you will, within the island, within Oahu and also the other islands within COVID cases. And that's to be expected, as one of the main foundations with COVID that we talk about in our office quite a bit is movement equals risk, right? So if you wanted no risk, if you wanted to buy down all the risk of getting COVID, then you wouldn't go anywhere. You'd basically isolate at home. You would make sure that even your family members, they isolated. You would minimize every point of exposure possible. And in theory, right, not in practicality, but in theory, we could actually get rid of COVID within a few weeks. But obviously, there is not just a public health consideration, as you guys know. The economy has taken a major hit. And as we know, there are second and third order effects of shutting down an economy, shutting down all movement. And so I think government officials, obviously, they have a really hard time because they have to try to manage that. And what I wanted to talk about as far as us managing expectations is, in lieu of a working vaccine, which is moving faster than I think ever before, as far as I think we're on a third phase trial for vaccines. Everyone's banking on a vaccine, but that's still going to take significant time. And in fact, it's not just getting a vaccine that works and ensuring that its efficacy is good so that it's actually protecting people, but then there's the whole manufacturing, distribution, and getting it out to the masses. So we're probably looking at honestly, and this could be wrong, but we're looking probably until the spring of 2021 to actually have a good vaccine and have it actually ready to distribute and have the manpower to actually, and the resources to do it. So what that means is, like many pandemics, and we can use the Spanish flu, for example, the Spanish flu took about 2 years, and it wasn't until kind of the second wave that it really started to have kind of secondary effects. We're in different times now. We do have some better outcomes for health now based on better treatments for this COVID. We do have more opportunity to travel than we did 100 years ago. So there, again, going back to movement equals risk, we have to be very smart about how we conduct ourselves, our community, and how we actually learn how to operate in a COVID environment. And so one thing, so just kind of give you guys the current epi stats as it stands now. So 1,418 cases now in the state of Hawaii, and 24 deaths. The good news is the case fatality rate here in Hawaii, as you guys may or may not be aware, is actually pretty good compared. It's actually pretty good globally, but especially within the United States, we have one of the lowest case fatality rates, and we also have one of the lower cases per capita. So it's interesting, and it's still, I still don't have a good answer as to why the state did not get affected harder earlier, especially because we had so much travel in the months of December and January, and we didn't really start, closing things off and getting a really good grip on things until March. And so, we can say we're just blessed, and also probably, I think, collectively, based on what I've seen compared to the States or the mainland is that collectively, I think Hawaii has done a better job at kind of being a one community as far as that collective strength that we talked about earlier, you know, and it kind of goes back to what Evan talked about with villages, is that, you know, there is a community kind of to do the right kind of thing approach that I've seen here. It's not everywhere, right? I mean, you have pockets of people that, you know, they choose to, you know, not adhere to the recommendations. But I think overall we've done a pretty good job here on in the state to do what we can to prevent the spread. But obviously we have seen more spread lately, and if you look at the epi curve, when we are coming down now from our second wave. If you look at there's different types of transmission, right? There's travel associated transmission, which I get it. If you're coming from a hot spot, obviously you're at a higher risk, right? If you're coming from the States, if you're coming from a different country that's a hot zone, you're at a higher risk. But the community transmission as a public health individual is where I'm really concerned, because that's where, if we keep having community transmission and those rates keep increasing, then it can get out of control pretty quick. And so, so overall, if you look at just within the last week, our number of cases per day, and that's kind of the big number we're tracking, has actually started to decrease. I think in the first week of, probably last week, I think was the highest case count we've had, you know, all throughout the whole entire pandemic. But those case numbers have started to fall in again, or they've started to fall again. So that's actually good news. The other point of data here that I encourage you guys to, encourage everybody to kind of pay attention to, is the amount of testing that we're doing within the state and the positivity rate. So right now in some of our major outbreak states, like Florida, for example, you know, we have anywhere of in between a number of 15 to 30, even 30%. And in the height of the New York city outbreak in March, mainly in March and April, we saw some areas that were showing over a 50% positivity rate. So whether somebody was symptomatic or not, and usually back then they were just testing symptomatic people, you were getting over 50% of the people that were testing positive. And what we want as a public health community, we want those rates to be as low as possible, right? So if you're testing, for example, in the state of Hawaii, we've now tested 131,000 tests, right? Some people have been tested more than once, but in general, over the last week, we've only had a 1% positivity rate. So that's really good. And that's really telling us that the disease is not as prevalent within the population as some of these other hot zones. It doesn't mean that it's gone away though. And so that's why we need to pay attention to the 7-day rolling average, because if we can keep these positivity rates at 1% or lower, or even 2% or lower, then we are going to be able to manage the cases that we do have. And the other big point I wanted to mention about this whole COVID response is, you may have heard this from one of the White House Corona Task Force folks, but we use it a lot within our building, is this is a marathon, not a sprint, right? And so realistically, we're still going to have to deal with COVID for at least another 12 months, if not longer. We're already 6 months in, and we're going to continue to see potential waves of infection go up and down. What we don't want to do, and you've probably heard this, is we don't want to exceed our hospital capacity to be able to care for our most ill, those that are most vulnerable to having severe disease or death from COVID. And the other point that this link shows is, it shows the total cases that we have received, and it shows those that are hospitalized, and it shows the age groups. And so, as you guys probably know, those over 60 years of age are at most risk for severe disease. And it's not just because of age, but oftentimes we have a higher population that are comorbid, that have issues like heart disease, diabetes, and cardiopulmonary issues that put people at a significantly higher increased risk for severe disease and death from COVID. If you look at our 0 to 19 years of age infections, we only have 131. So that's about 10% of the total infections. We've had relatively no hospitalizations, with maybe one exception, but I think that was reclassified. When you get into the age group of 20 to 39, we've had 475 infections in that age group. And out of that, a very small number were actually hospitalized, only 12. Only 12 of those 475 were hospitalized, no deaths. And the reason why most of those hospitalized cases, those individuals, even though they weren't very old, they did already have comorbidities that made them require hospitalization. Then you get into the age group from 40 to 59. And this is where you start to see a little bit more increases in hospitalizations, but still relatively few deaths within this population. And then, of course, as you get into your over 60 and over, we've had excuse me, let me get the numbers right here. We've had nearly over 300 cases in that group, and most of our deaths, 20 of the 24 so far, have come from that group. And obviously, those also had the most hospitalizations. So what does that all mean? Well, I know here in Hawaii and also in where I'm from in California, you know, that we have a lot of multi-generational living situations, right? And so we have some folks that are over 60 but completely healthy, and usually, even though their risk increases because of their age, they're generally in a better position than those that have comorbidities. So here's another lesson that I want you guys to take away, is that we are only as strong as our weakest link within our households. For example, I have 4 daughters, and my oldest right now, you know, she's going to be a senior this year at IAEA, and she has, you know, she has a lot of friends. You know, she had a lot of trouble between her and I, just trying to, you know, hey, you need to stay home. You know, you need to limit your exposure. And I told her, you know, even though we don't have any comorbidities at our house, if we did, we are only as strong as our weakest link, excuse me. And so what I say is, my daughter is very healthy. She's very fit, physically active, no comorbidities. But if she's the one that has the most exposure to people, she's still at risk for infection, and she can be an asymptomatic spreader. And so if we have somebody that has a comorbidity in our household, like if my father was here, or we're taking care of somebody, you know, that's at risk, then she is the weakest link, in the sense that she is at risk of infecting, you know, somebody who's comorbid. And that's the biggest issue. So I think going forward, in talking about our villages, is that it extends outside of just, it extends past, it goes into our neighborhoods, into this Ohana concept that's more than just the immediate family, that's our community. So my Bluetooth is about to die out here, so I'm going to get back to my regular earbuds. Can everybody still hear me okay?
Yes, still hear you.
Can you guys hear me okay?
Yep.
Sorry about that. My audio is, just want to make sure I can still hear you guys. Same system.
Why don't we take we'll take a
Okay,
quick,
there, I can hear you.
we'll take a quick pause, and we're just going to do a quick photo shoot so everyone that doesn't have a video, if you can put your video up, we'll get back to the presentation right after, but I know sometimes people have to go exactly at 8:30, so it's best that we do this, get back to Darrick's presentation. I'll finish up the meeting after his presentation, and then Q&A we'll do after that, so however much time that Darrick has, as well as how much time everyone else has. to share. So,
Sorry, my comms are back up. Sorry about that, Evan.
oh, no problem at all. So we're just going to do it very quick. So Lisa, Kara, Francine, Marshall, if you guys are interested in sharing your, oh, whoa. Hey, Darren. If you can put your video up, won't be that take too much time. And this is a new thing.
Okay, here we go. I'm gonna snap it on my end. Okay.
Do you want to do a countdown, Ryan?
Yeah, I'll do one more. Okay, here we go. Ready? 3, 2, 1, smile. And everybody wave or shaka. 3, 2, 1. Okay, good. Got it.
Okay, back to business. All right,
Okay.
so Derek, you want to go back?
Yeah, I'll wrap up here. So I know I gave a lot of information, and I really wish I was able to get the links shared. Hopefully, you guys have a chance to take a look at that state health department, because I think they really do a good job. And I know some of the epidemiologists working at the state, and they're working their butts off trying to make sure that they can get timely information to the community. And so knowledge is power. Obviously, that's another lesson that's obvious, but it needs to be reinforced. So we talked about managing expectations, understanding that this is a marathon, not a sprint. Understanding that we also have an individual, responsibility, but also we have a collective responsibility to take care of ourselves. And I gave the example of my daughter just trying to understand that, I was 17. I was going into my senior year, many years ago. But I remember wanting to enjoy, and I lived in Fresno, California. I mean, it wasn't the funnest place to be. Let's be honest. We're a lot of agriculture and farmland everywhere, and so here on the island, I mean, I really do think within reason we can get out. We can still do our outdoor activities. We can still go out and run our errands, but remember, movement equals risk. And so if you can avoid that, if you can avoid those social gatherings where, we looked at a lot of the community transmission here within the island. I didn't touch on this, but a lot of it is communal, and it's hard because families need to, we're sacrificing so much right now to try to curb to flatten the curve, and we really did a good job. The one thing I didn't do was just applaud the state of Hawaii, because like I said, we've done exceptionally well in almost every single category. And maybe some of it was, divine intervention. Maybe it was just that we were very hardworking and we're fortunate and lucky, whatever you want to say. But overall, I think there is a moment that we should pat ourselves on the back. But again, we can't let this thing get out of control, because we still need to make sure that we can protect every life and try to prevent as much life loss as possible. So with that, I'm certainly willing to take a Q&A if you guys have any questions. And if I don't know the answer, I'll be up front and I'll try to get back to you guys. So standing by for your questions.
Okay.
I don't have a question. I just have a comment and to some extent an opinion. I just retired from the Department of Health, and part of my work had to do with interaction with the Sarah Park and Dr. Anderson and the state epidemiologists. And my public health degree is in epidemiology and community health, which I never used for decades until this pandemic hit. And I do want to give a shout out to them for their consistent messaging and their being in meetings with them to know how thoughtful and deliberate they are with their messaging. So I think they deserve a lot of credit, none of which comes to me at all. My role was to look at the impact on the population of people with disabilities. So that's just my comment. But I also wanted to say one more thing that truly bothers me watching the news, and that is the we have a large percentage of people here everywhere I go that I see doing a fairly good job of social distancing and wearing masks. Perhaps it's because we have the ability to go outdoor. We've had the ability to be outdoors all year. We haven't had a winter, so to speak. So as I walked in the neighborhood and stuff, people were very, had their way to escape being outdoor. But it does bother me that for too many Americans across the country, the pronouncement that we are losing our freedom or something has been, all sense of civic obligation and doing something for the communal good seems to have gone out the window for a small portion of the population. And that's very, very disheartening to me.
Yeah, that's a good point.
Okay, so I'll have us go back to Q&A, and I know that we have a lot of questions, so more than likely it's going to be till maybe even 9 o'clock, which is totally fine. But just for everyone else, I'm just going to kind of close this up real quick. But I guess the one question, and this is before we kind of finish the meeting, Darrick, that, do you think moving forward that we can continue to open up safely? That's kind of, I think, the big question. We'll close up and then get back to all the other questions.
Yeah, I probably the most important question about balancing and I think we have done. The good news is, like I said, we've started to already come down from the second wave that kind of started hitting us within the last month again. The trickiest question is going back to movement equals risk, is that if we open up for tourism, or as we do, that will be, I think, the bigger test that we just don't know yet. A lot of it is in the legislation as far as how do you mandate a test? If you can't mandate a test, how many people will actually get tested? For example, I can talk about what we're looking at right now. Is we're looking at an Indo-Pacific, which is basically all of the Pacific for military, for any entry or any movement. We're looking at a pre-departure test from wherever you're coming from within 72 hours. If you don't get the 72-hour test, then you have to get it when you get here within 24 hours. Then there's a hard quarantine, meaning a very strict quarantine. And then there's an exit test on top of that at day 12. So it's a very, with the military, obviously we have a lot more flexibility or leadway to mandate of military members. It starts to get really tricky with the civilians that work in our federal system, as well as our dependents that are attached to our military personnel when we move. And so one of the things from the military is we don't want to introduce disease into a state, a territory, and especially a host nation, because that can start to sever the ties between, like, the government of Japan, for example, and the government of South Korea. So I think we're usually, the military has been about 2 weeks in front of what the general population does, and we're usually about 2 weeks behind in seeing what the civilian population does and seeing whether or not that was a good move or not, right? So we're very conservative in that sense of public health, making sure we try to buy down as much risk. I can't give you a strong answer. I think we need to probably, my own opinion is we need to try to open up, but we need to be remember the link I showed you, we need to really look at are we testing? Do we have the contact tracing from the local government and communities to be able to get cases quickly identified and try to stop the outbreak, right? That's like the core of public health for breaking the chain of infection. And so if we can do that, then I think we can open up more and more. But again, once we start hitting a certain threshold, it's like it's almost like a juggling act. You got to kind of go back and forth, and that's what I worry about right now within the island. Is there's a balance, right? People are also, there's a livelihood. There's people need to work. They need to feed their families. They need to pay their mortgages and their rents, and It's really tricky. Again, I'm glad I'm not a politician. That's all I can say right now, because it is, no matter what, this thing has become, politicized, and that's all I'll say about that. And that does not help when it comes to public health. So moving forward, I think let's control what we can control, impact our communities the best we can, make smart decisions, and I think that's about the best we can do right now. Thank you.
All right, well, perfect. Yeah, again, I do have questions myself. I know we all have questions, but just for the sake of time for everyone else, I'll do the logistics of wrapping us up. For the last thing is typically the four-way test. I guess I will call on, who will I call on? I guess Debs, if you don't mind doing the four-way test, we'll call the meeting to order and then get back to the Q&A such that we can continue getting educated.
Sure. Of the things we think, say, and do, first, is it the truth?
The truth.
Second, is it
Fair
fair
to
to
all
all
concerned.
Third, will it build
Will it build goodwill and
and better
friendship?
friendships? Fourth, will it
Will
be
it be
beneficial?
beneficial to all concerned?
And fifth, will it be
fun?
fun?
Well, I do want to say thank you for joining me for this meeting. I know this is a little bit longer. I do want to give Darrick a little bit more time. I know you have questions, so stay on as much as you want, and go ahead and ask your question. So, Alan, I know you had the first question, so go ahead and ask your question.
Thanks. Can you share with us, what's the military's policy right now in terms of quarantine and testing, and sort of compare and contrast that to the state of Hawaii's requirements?
Okay, I'll do my best to give you as much clarity, understanding that, of course, under the Department of Defense, there is we are here in Hawaii. We are part of the Combatant Command Indo-Pacific. So there is a combatant command that's over all the services, all the components. So the Marines, the Air Force, the Army, and the Navy, and to some extent the Coast Guard. So every component can be a little bit more restrictive. Every service component can be a little more restrictive than what Indo-PACOM has, but essentially, again, right now there is no required test for blanket Indo-PACOM policy coming in. That could change, and that likely will change within the next week, and that's what I kind of mentioned. The commanders at the highest levels want to make sure they're not introducing COVID into either a state. So that includes Alaska and Hawaii, also not into Guam, because Guam has very limited resources on the island, and also within our host nations in Japan and South Korea. So for my headquarters here at Hickam, so my headquarters is the old barracks from the bombing of Pearl Harbor. So that all the airmen that were there, I don't know if you guys are familiar with Hickam, but it's a very large building. We have very strict requirements. We require a test within 72 hours of departure, a documented test with obviously wearing face coverings, and but essentially right now most people are getting a test within 24 hours. They go into a hard ROM. ROM is basically the military term for quarantine. I won't get into all the specifics, but ROM means restriction of movement. So that's basically what a quarantine is. During that quarantine, people are allowed, they prefer other people bring them groceries, for example, to limit the amount of interaction that the service member and their families have during this 14-day period. So they're very good at trying to prevent people from, obviously, if they're staying at the Halikoa, for example, they're not allowed to leave at the Halikoa during that 14-day period, except for a medical, emergency or for testing. So we're really, I think we're really good, and you see some of the positive cases that we have had recently on the island have been from people coming in either from the States, and then they get that test and then they're positive. Now, whether or not they infected people or not, we don't know. We know a lot of times with the testing that sometimes people have had it already for a certain period of time, but they still show RNA fragments of the virus in the test. But we treat them as if they're positive and infectious, and we put them in isolation immediately. The quarantines that we have as military individuals, obviously we try our best to comply with the state requirements. As a federal agency, we do have a lot more leadway to continue to go to and from work if need be to do mission essential duties. But we certainly take quarantine as serious as everybody else. So I would say in general, we're doing a very good job from compliance. I can't really speak to the other services, but like I said, like the Navy, for example, they still have to do at least the bare minimum of what the combatant command asks of them to do, which is as much as what the state's requiring at this time. Hope that helps. I will say one more thing. Let me just add on. In Korea, South Korea has been one of the models of response. If you've noticed, they have a robust contact tracing program. I will say that there are some unique things with South Korea in that their government is able to get and use cell phone data a little bit more easily. They have access to, and they can kind of do a little bit more GPS like tracking type stuff with their apps, and they're very kind of high tech. That's the model system. It's not necessarily gonna fly, for lack of a better term, with the U.S. population at large. But we are also exploring other ways to kind of beef up our capability to do contact tracing in a more aggressive manner. So in South Korea, they do require a test for all entry into the country, and Japan has just moved into that as well, along with the quarantine, along with an exit test too. So yeah, I hope I answered your question. Thanks.
Awesome, thanks, Alan. So anyone else? You can just go ahead and ask it. I think at this point is probably fine. You have a question. Okay, well, I'll ask a question. One of the struggles that we're coming to grips with is we're on Zoom, and I'd like to transition us back to in person. Right now, it's kind of going to be at a restaurant, so there's things that we can do to alleviate some of the sharing of food, such that it's just everyone picks up a little box. And just in regards to any sorts of, I guess, restaurants or meetings that's 10 or maybe even a little bit more. I know 10 is kind of the max of what it's supposed to be, but in restaurants it's kind of different. What would you say the risk of COVID transmission in a case like that?
Okay, what I will do also is I'm sharing a document with you, Evan, as well, and it's going to upload right now. And this is kind of what we've adopted here in our headquarters building or at Hickam. And it's called, to be politically correct, we didn't call it the 10 Commandments, but it's essentially like the 10 enduring principles to come back to work safely. And I think this would be a really good example of just some basic, kind of basic things to consider when doing a in-person meeting. We do have physical meetings. We try to, or is everybody able to see that? Okay, so this is a notice of 10 different workplace requirements we have for our headquarters building, and obviously it's a lot of the stuff what the CDC recommends. What we did was we used a lot of common sense, but we actually used an engineer to determine each room's occupancy limits based on ensuring that we could have a 6-foot space between individuals. And in that case, people within that area didn't necessarily have to wear face coverings, but obviously we still recommended the face coverings, even if just to be that much more safe, unless you were briefing or you needed to speak at the microphone. Then as long as you were like within over 6 feet of distance, then we made the assumption that the risk of transmission in that area is small. Is it down to zero? No. But at the same time, we are doing all these things every time we walk in our headquarters building. These are our 10 commandments, if you will. So we're always practicing the good hygiene, obviously washing hands, bringing hand sanitizer to a meeting. We're always avoiding, touching to the most extent possible, touching our noses, our mouths, just to prevent that transmission from surfaces and or from hands. Talked about the 6 foot of distance, more if you can. If in motion, wear face covering. So in our actual work cubicles that we have or offices, we don't wear our face coverings, for example, if we're just at our desk by ourselves. If we had a situation where we couldn't ensure 6 feet of distance, we would try to move that, re-engineer that work area so that we could let people work in that area, or they would have to wear their face coverings. And then obviously if somebody's, not feeling well, certainly don't come to a physical meeting, don't come to work. Obviously that's kind of it goes without saying, but it's important to mention. And basically it's kind of like just be smart about things, do the right thing. If you have a very low risk tolerance for, if you're feeling ill, if you just have an upset stomach, you never know what it could be. I was tested for COVID about a week and a half ago because I just had an upset stomach and I just wasn't feeling good, kind of tired. Luckily I was negative, but I didn't come to work. I made sure that I didn't go to that meeting. I made sure that I didn't put people at unnecessary risk. So I share this with you. This is a product that one of my graphic designer guys did from California to help us out, and we got this printed out. But you can certainly adopt if you guys want to for your either work centers within your however you guys want to use it. Thanks.
And Jamie, did you have any questions? I know you wanted to join specifically for this meeting. Did you have any questions you wanted to ask?
No specific questions. This is really informative. Yeah.
Awesome. And then Ryan, did you want to, ask anything in regards, I guess, for your job or any questions you might be interested?
No, it was just very, very informative. Just on a side note, my wife works for the DoD, and her offices are actually at Joint Base Pearl Harbor, but they've been working at home since March and not allowed in the field or anything like that. So, but it's interesting to hear. So it was very interesting to hear your perspectives and your thoughts on what's happening there.
Yeah, I thank you, Ryan. My wife actually works at the terminal there on Hickam, and so because of her job and because of luckily our kids have been once school shut down. I mean, they're a little more grown. Our oldest can kind of watch over the kids. My wife is able to telework, and that was another thing that I want to mention is that teleworking, it just tries to prevent the amount of people congregating in one area, right? Just like we're doing a Zoom right now, this is kind of a telework versus coming together. So I really think, technology, 5 years ago, we wouldn't have been doing this it wouldn't have worked as good as it is right now. And I'm actually very hopeful for the future. There's still nothing like, we're all humans, right? We all enjoy like interaction physically, with people and stuff and community. And so I look forward to the day we can get back there. It's made me appreciate it more, but at the same time, I'm also kind of like accepting this being somewhat of the new norm or the current norm for now.
Awesome. Pat, did you have any questions? Pat's one of the high ups or directors at Kahala Nui. So I know that, you were very strict coming into COVID land, but do you have any questions specifically that you wanted to ask Derrick?
Well, I was kind of interested in what South Korea is doing because I've heard a lot about their way of communicating and letting people know about areas to avoid and so forth. But all I heard was something very brief. If you can elaborate on that, that'd be interesting.
Yeah, one thing about, if you're talking about the Republic of Korea, South Korea itself, or are you talking about the military efforts within there?
The South Korea itself.
Okay, so I don't have as much information. I do have a general, some general key points about South Korea. So obviously they've used technology as a leverage for combating the virus. And as I talked about it, some of it, talking with our legal teams there, they had the ability to not only notify people that they are able to notify people that are in proximity to those who tested positive based on cell phone data. And because I haven't seen it, I don't necessarily know exactly how it works, but the government has the ability to tap into those programs using software. We do have access to those software, and I know that some of our universities, including our major universities, including Johns Hopkins, working with the CDC, they're looking at different ways to enhance that. Again, there's some legal considerations about protection of private information, cell phone data. My personal opinion, I think we should go ahead, and it goes back to doing the communal good. Sometimes we have to sacrifice a little bit of our personal, I guess our norms to try to combat this virus, but that's just my own opinion. I don't know that we're going to get there. I think one of the other things that you mentioned and that the South Korea does, and I think our state health department is trying to do, is they're trying to identify. Our state health department here is using zip codes to try to land where more infection is. The problem with that is it usually coincides with where more population is in a certain area, and so it doesn't necessarily show you exactly which particular neighborhood may be hit. I think that they're a little bit more exact as far as their areas that they're telling people like to avoid, but they have certainly opened up quite a bit. I think I think in general both Japan and South Korea have done and a lot of the Southeast Asian and the North Asian countries have done as a collectively is a better wear of the face coverings, right? That has been a norm within cultures after the SARS outbreak in 2003. And so I think we're trying to adjust as the United States within the last 6 months on this, whereas a lot of our partners in the East have been doing this for 15 years plus.
Okay, thank you.
Any other questions? I have a bunch of questions, so I just want to make sure everyone else gets their time to ask any questions. Does anyone have anything that they did want to ask about specifically? Okay, perfect. So I think one of the big questions is about herd immunity and the concept of is that appropriate? And I without getting into the politics of any of it, just want to ask the question of, is it a reasonable sort of defense of combating this issue, or is it that COVID is just different in terms of a virus than a lot of the different ones, such that herd immunity doesn't work?
Yeah, that's a great question, Evan. From the latest information, and I'll have to go back to get a link to you guys, but we are hearing that unfortunately with COVID that immunity is only lasting about 4 months, and before the protectiveness of your antibodies starts to kind of wane off a little bit. And so what that means obviously is that the concept of herd immunity, we know that oftentimes with viruses that they offer sometimes lifelong protection. Sometimes you need a 5-year booster depending on what immunization, pick your poison. I think we're still learning. It's still almost too early to know if that's for sure. We need more data to be able to account for any factors that may increase that time frame or even potentially decrease that time frame. But I don't think you can have significant hope for herd immunity in a situation where your antibodies only last 4 months, because then you can become reinfected, right? So then it kind of defeats the whole, well, if a certain, because with herd immunity, you know, usually depending on what kind of virus, but usually you're looking at anywhere from 70 to 80, even up to 90% of people being infected to be able to start getting herd immunity results where you start breaking the infection. I don't, my confidence in the 4 months is not where it needs to be, but that's what I know at this point.
Mhm. Yeah, I definitely have heard reinfection cases already of people that have gotten it. It's kind of across the board of if it's worse or better or not as bad. So
And yeah, Evan, just sorry to jump in there. Just one point about the reinfection, and then what they're trying to figure out is, you know, when you start doing viral cultures, a lot of times what you're seeing with this with this particular virus is the persistent positive. So the CDC just changed its recommendations for releasing people that are positive, as far as how do you release them from isolation. And there was two strategies. There was a test-based strategy, which was 2 negative tests greater than 24 hours apart, and then your symptoms had to be resolved from symptoms for at least 3 days, and then you couldn't have had your onset of symptoms had to be from, like, I believe it was from 10 days, and they keep kind of changing that. But bottom line, what I'm trying to get at is the CDC has moved away from that test-based strategy. They prefer a time-based strategy. And the reason why is, as we've seen, you guys heard about the Teddy Roosevelt Navy ship out of Guam, that there was over, I mean, this was the biggest outbreak we've had in the DOD, 1 death. I think there was over 1,500 cases out of this ship of 5,000. What they found, and it's a really great case study that's being done right now, is about 30% of those people continue to test positive. And we've seen this in South Korea data too. They tested positive even, you know, up to 6 weeks after they contracted the virus or were positive. And so what that is it's when we do the nasal swab and we're collecting, it's a PCR test, right? So it's looking for RNA, and those RNA fragments still, it's dead virus, but it's still there. So most studies show now that you're not infective after 10 days. And so what they're trying to do is they're trying to not have people still be in isolation for up to 2 months. They want to get them back to work. I think what they're trying to figure out right now with the with the immunity and is your response to the virus is often dictated how symptomatic you were. They're showing evidence that the more symptoms you have and the longer you had, the harder infection you had, the better immune response that your body kicks out. But for those that are asymptomatic often and they're positive, their body didn't respond as it normally would during a regular, you know, flu or something. So they don't get the same antibody response. And so one is not one, you know what I mean? It's like everybody has an individual response, and that's what's so complicated about this right now.
I guess another question, anyone can hop in if they do want to. I mean, I think at the end of the day, this is good public information for me as well. In regards to this versus a lot of other viruses, would you say that this is a worse in the case of the fact that the death rate is a lot lower, but the transmission is a lot higher? Sort of where would you rank this in regards to some of the historical viruses that you've seen or studied or been a part of?
Yeah, so just quickly with H1N1, we talked about earlier when we first got on this morning. I was involved with an H1N1 response both at just north of Sacramento at Bill Air Force Base and at Misawa Air Base, Japan, in Aomori Prefecture in Japan, northern Honshu. And the thing about H1N1 is it probably was a little least, I think the infectivity was lower than coronavirus. I think this one spreads easier. I think it's a little bit more virulent, meaning it has a higher case fatality rate, higher hospitalization rate. I was sharing the numbers with you. We estimated that in 2009 to early 2010 for the H1N1 swine flu, as they initially called it, there was about 60 million infections. They estimate. They did not test and confirm that many positives. It's based on estimates, based on influenza-like illness and ER visits and doctor visits. We probably have a lot more than 4 million cases, right? We weren't testing all the asymptomatic transmission that was going on. We're still not necessarily testing all the asymptomatic transmission, because you're not getting tested unless, you either were a close contact of somebody who was positive or you have symptoms yourself. So I think I think the numbers are certainly higher, but certainly the deaths are a lot higher than what we saw with H1N1. So I think in terms of is this one worse than H1N1? I think so. The other thing is, with H1N1, we had with Tamiflu, we had a good therapy pretty quick, which helped decrease the death rate, or prevent the amount of deaths. And also with H1N1, with the vaccine, may have offered some protection, but obviously it wasn't offering that much protection for that flu season. So I think in terms of where we're at, I think this particular virus is worse. When you look at something that is bloodborne, so this is like respiratory droplets, right? And there's limited aerosolized, evidence like in indoors for transmission. This is a lot different than Ebola, right? Ebola was not airborne, unlike the movie Outbreak, which the famous Dustin Hoffman says, "Oh, it's gone airborne." The Ebola outbreak in 2014 and the one currently going on in Congo, this is infected body fluids, mainly blood, but also you have to be in very close contact with people to get this. Ebola is a lot more deadly. It's a lot more, the case fatality rate can be as high as 70, 80%. So certainly it's a nastier virus, but it doesn't spread as easy. And that's, a lot of people make comparisons. Well, during the Ebola outbreak, we didn't allow it to get into the United States and infect everybody. Well, it likely wasn't going to happen anyway, because of the type of virus it is. So I think this is probably, it's not as bad of a virus if you have it, but for the community, it's obviously infected and killed a lot more people in the world than what Ebola has, even though Ebola was really bad. It's just like apples and oranges.
I see. That kind of brings up two questions, or two follow-up questions. One for the vaccine, you touched on it a little bit earlier regarding the expectations. And I think that, I've been following it as well, that University of Oxford kind of came up, I think they're in like stage 3 trials. What should be the honest expectations and sort of why there is such a lag from, them doing all of this sort of work? And if you can kind of help me or Alan or whoever else is here kind of unpack what actually goes into like trying to find a cure, and sort of how does it logistically get to a population, and what is the realistic expectations of like when it does get to the population that it'll be available in that sense?
Well, I will give you a very brief explanation. I will admit that I am not necessarily the expert, subject matter expert on this particular topic. Some of our virologists and some of our folks that work in immunization and allergies can probably answer the manufacturing and distribution process a little bit better. But from my understanding, as a general knowledge, the standard for introducing immunizations and vaccines is obviously there's ethical concerns, and there is as we've seen, there have been adverse reactions to vaccines, but for the general population, and I don't want to get into the whole vaxxer, anti-vaxxer kind of debate, I'm a proponent of vaccinations because I just trust the science. And yes, there are potential outcomes, but I think that part of the reason why there's so much rigor in going through phase 1, phase 2, phase 3 trials, for one, there's two factors. There's safety and then there's efficacy, right? And obviously you need both, or you can't have a successful immunization program. Vaccines are also challenging when you're trying to develop one off the fly for a new particular strain. Yes, we've had coronaviruses. All of us have probably had a coronavirus in our lifetime, right? And a lot of common colds are typically coronavirus in nature. The problem is it's been very hard to develop a vaccine for coronavirus itself. It's just the way that this particular virus behaves, potentially how it adapts. And as you notice, there's not a vaccine for the common cold, right? We don't, because there's so many variations and but oftentimes it's because of the coronavirus. The fact that we're making headway and showing promise on already moving to phase 3, it's awesome. But Dr. Fauci, you've probably heard him, and maybe the FDA, the expectations is we can have a vaccine. Local or open source reporting is showing that, or is telling that China is actually already vaccinating their military personnel. So now, how is the efficacy? What is the what are the adverse reactions? So when you look at trying to implement and execute a vaccine to vaccinate potentially the entire population of the United States, you're buying more risk if you're giving that vaccine to 300 million people. You may miss the population, like we're talking about somebody who works with a population with disabilities. Well, if you're working with a population with comorbidities and you're trying to vaccinate them, unless you get usually a live virus has more risk. If you're using an attenuated or a killed virus, basically as a traditional vaccine, then there's less risk. But obviously there is all these complications that I'm not an expert on, but I know there's a reason and there's a basis for why it takes so long. The policymakers, the manufacturers, and the distributors, obviously there's always issues with cost. Nothing is, one thing I learned in 6th grade, right? There's no such thing as a free lunch, right? Somebody is going to pay the piper, right? And then there's always the consideration of profits, right? So if there's manufacturing companies, they have employees, they have workers, I sure as heck hope people manufacturers aren't price gouging this. I hope they make it accessible, but it is going to be a monumentous effort to try to vaccinate America. And oh, by the way, there's going to be competing demands globally for this. So that's I can't give you a great answer, but that's the dynamic that I look at, and I think that's what's so challenging about this.
Alan, you have any other questions? I have just one more, and then I'm kind of called.
No, Darrick, thank you very much. It's been really informative and helpful. I have to jump off, so I just want to say thank you, and I gotta go. Okay, bye.
Did it.
All right, so one last question, or just about COVID stuff. I think in particular, again, just for my knowledge, would you say that the fact that, I guess, what's the, you said that there's sort of that particular within a society or within a population that it's a really careful balance of reopening it and ensuring case loads are low such that we can continue to kind of do stuff. What would you say that kind of point is? And you don't need we won't point specifically to response or government response or whatever, but just in regards to us, if it helps to compare it versus the mainland US, if you can kind of compare and contrast it, that helps to answer that question.
Yeah, I think the big thing here for Hawaii and we'll just use the state as a whole. One thing that I'm most concerned with is hospitalization rates in our capacity. So I think I'm sure. So one thing I didn't talk about a lot was modeling. There are hundreds of models that people are using, and a lot of times the best approach is using multiple models, and then that even comes into a whole database, and the analytics on that is, as a statistician, I'm not a guru, but obviously did a lot of public health statistics and a lot on curves and modeling, and the modeling that I've seen has been like here to here. There's been a range, right? And so you try to find the balance, and it's not perfect because you just can't exactly predict all the variables that go into, like you have to plug in, well, what about if you start bringing in more tourists? What happens if, there were some concerns about seasonality, but I think that's pretty much went by the wayside now. I think this thing can transmit amongst people in almost any environment as long as you have people close enough to each other. But there are variables with in teleworking, for example. If you're limiting the amount of people in a work environment or in a public space, a lot of the models initially didn't account for that because, or they accounted for it, but it was a guess because we had never done this before, right? We had never, and that's what I was trying to compare with H1N1. Our response has been draconian compared to what we did in H1N1. And when you look at when a national emergency was, a public health emergency was declared at the federal level, and again, a lot of it may have been based on we didn't see the kind of fatality or the outbreak like we saw in Italy. We saw it in China, but then obviously, I don't have a lot of trust in the data there, unfortunately, just because they closed off a lot of their information to the public early. But what we saw in Italy, New York, in one of the biggest areas, I think, and I didn't bring this into too much consideration, but nearly, not quite half, but almost half of our deaths nationwide have been somewhat related to nursing homes and or skilled nursing facilities. And you've seen this data in Los Angeles County, in Michigan, in New York, and also New Jersey, and throughout the nation. I think we've done a better job now. One of the things I think we shouldn't have done, and I'm sure there was a reason, but bringing sick patients into these nursing facilities for care, that was kind of a perfect storm, right? From a public health standpoint, you don't want to put sick patients next to vulnerable patients. And that's kind of what I was getting at is I think our threshold is going to be here in the state is going to be primarily based on hospitalization rates and whether or not that, and or if we start to see a lot more fatalities, because with fatalities, not only from a public health standpoint, obviously, that's when you start getting the public demand of the government to intervene, right? And so once that happens, if that does not happen, then I think we're going to continue to accept some risk, right? We knew COVID was going to kill people people were going to die. We didn't know the rates. There was projections nationwide anywhere from 100,000 to 2 million, based on the end of the fiscal year. And we're nowhere near that 2 million, but certainly there has been a lot of deaths, over 140,000. Here on the island, I think we have done extremely well. And considering how much we do have an aging population, we do have those with comorbidities, but I think there's that factor as well. So I don't have a pinpoint, but I'm sure the state health department probably has some trigger points, just like we have our own trigger points in our own building, for example, in our own headquarters, where if we start to see more than one active case within a certain section of the building, we're going to start pulling back, at least temporarily, the amount of people we have in the office. We're still teleworking to some level, but we've kind of returned back to work. And luckily we haven't had any, we've had I can't give the number just because of operation security,
but I can say we've had hardly any cases of COVID within our, headquarters building of over 1,000 people. That number is very, very low. That's all I'll say. And the point is even though we reopened up, I think it's based on those measures, those 10 measures that we enforce. We've kind of taken that as a collective ethos going forward into our workplace. So it's that communal effort that I think is going to help. Sorry, I kind of got off on a tangent there, but
this is all great information, and I know you're passionate about it, and I enjoy learning, and that's why it's funny that after every meeting I end up talking for a while, just because it's just a very interesting topic. I bring in the speakers too, so I find it interesting myself. So I do want to say, one, I appreciate everything. I know you're a busy guy. I'm a busy guy, but this is important. I think that these are all things that are valuable to our club and the community.